agenda. But first, we're actually going to go around. We have a number of new folks here, and we're going to start with introductions. And I'm just going to kind of sort of go in order of what I have here. So actually, Anne, why don't you introduce yourself? We'll start with you. You're off mute.
Good afternoon. My name is Ann Mahoney. I'm the Wyndham State's Attorney. I've been here since 2016. Before that, I spent 20 some odd years in Hartford trying sex assault cases. Have done some out here. Love the SAFE program. Think it's wonderful. It's every prosecutor's dream, and hope we can expand it. I'm on mute. I'm not, but I'm getting you double.
No, we hear you, or at least I hear you.
Yeah, I hear her too, just fine.
Yeah. Mariel, we'll go to you next.
Sure. Hi, good afternoon, everybody. My name is Mariel Daniels. I'm the Director of Regulatory Advocacy at the Connecticut Hospital Association, and I attend most of the state-related groups for sexual assault response in the state.
Thank you. And Beth? Oh, no, Beth. Beth. Yeah, and then Lucy.
All right.
Sorry.
No, it's perfect. Hi, I am Beth Hamilton. I'm the Executive Director of the Connecticut Alliance to End Sexual Violence. We are the statewide coalition. We have 9 community-based sexual assault crisis programs who go out and work directly with victims and survivors, and who are doing oftentimes the accompaniments in these forensic exams.
Hi, and I'm Lucy Nolan. I'm the Director of Policy here at the Alliance with Beth, and I'm also the Chair of the Psaki Work Group.
And Dr. Cordiano?
Hi, sorry I'm on video. I'm trying to eat. I worked last night. I'm Alexis Cordiano. I'm one of the emergency physicians at Hartford Hospital, and I'm the Connecticut College of Emergency Physicians rep on this committee.
Okay, thank you. We're going to go to Colleen.
Hi, I'm Colleen Violet. I'm the Health Program Supervisor for the Office of Injury Violence Prevention for Connecticut Department of Public Health.
Thank you. And Dante?
Good afternoon, everybody. My name is Dante Gennaro, and I'm here on behalf of the Office of Communications at the Connecticut Department of Public Health.
Lori?
Good afternoon, everyone. Thanks for having me. Nice to see you all. My name is Lori Johnson. I am the Chief Marketing Officer and partner at Converge Marketing, a contractor and service provider for the Connecticut Department of Public Health and other state agencies.
And Denise Poncini?
Hello, everyone. I'm Denise Poncini. I'm Judicial Branch Legal Counsel to the Office of Victim Services.
Thank you. Mary?
Good afternoon, everyone. Mary Kazicki, Deputy Director with the Office of Victim Services.
Linda?
Good afternoon. I apologize. I'm pouring some water. I'm Linda Semino, and I'm the Director of the Office of Victim Services. It's great to see everybody.
Jean? Thank you, Linda. Jean? Jean, are you on? Maybe not quite.
Excuse me, sorry. Hi, I'm Jean Weisbrod, and I provide the administrative support for the committee.
And Cheryl.
Good afternoon, everyone. My name is Cheryl Black. I'm a newly added member to OVS, Administrative Assistant. And it's nice to meet everybody.
Cheryl will be taking over for Jean next year as we begin 2023 to do the minutes, and she will be the one who will send out the invites, and you will be getting to know her quite well through the committee work of the committee. So we want to welcome Cheryl, and we also want to thank Jean for all of her work on behalf of the committee for the last couple of years. She's done a wonderful job with that. Did I miss anybody? Okay, and of course, I'm Denise Covington. I'm the SAFE Program Manager, and I am chairing this meeting. So welcome everyone. We do have a quorum. Did everyone have a chance to look at the October 5th minutes? So can we have a motion to accept? We'll discuss in a minute, but can we have a motion and a second?
I'll move.
I can second.
Okay. Any discussion on the minutes? Okay, by a show of hands, if you can, all in favor, if it's approved.
Aye.
Any nays? Abstentions, and I know we have a couple probably.
Ironically, maybe I should not have done the second because I was not there, so I think I need to abstain. So I apologize
Okay.
if I just mucked up the works.
That's okay.
Same with me.
Okay, that's
I'm curious.
okay.
I'd like to see these materials though that are mentioned in the minutes, but I have to abstain too.
Okay,
I would abstain because I wasn't obviously on the meeting.
okay. Thank you all. Okay, so the third thing on our agenda today is the revision of the DPH pamphlet update. And I know that Robin was not able to be here today, so I'm going to look to our visitors from DPH, Colleen, Dante, and also Lori. If y'all could maybe provide the group with an update on the status of the pamphlet. Maybe explain just a little bit too about for those of you, for those who are new, if you could maybe provide a little bit of an explanation as to what it is as well.
Sure, I can get started and then I can have Dante, I think, is going to step in too. So we apologize. I am a little newer to the process. I'm newer to the unit. So kind of coming in on the hopefully tail end of approving this or updating this pamphlet here. So we've been working, I believe it was like the past 2 years to get this pamphlet, a brochure out to services, and we're on the final stages of approving and kind of finalizing it. But there are a few revisions that we're hoping to make to it before that process is completed. Dante, do you want to talk about those a little bit?
Absolutely. So, and again, good afternoon, everyone. So, as I understand, this is supposed to be a resource guide for individuals, victims of sexual assault. And so it was presented to the Office of Communications just to have an overview and see what we thought. And we were very impressed by the entire document. It's very lengthy and full of really great information. There were a couple of concerns that had come up pertaining to a couple of previous issues that I was made aware of. Printing, wanting to know where who would be responsible for printing these materials out. So currently the Connecticut Department of Public Health is looking at our internal resources to see if that's something that we would be able to take on and be able to mass print. We do have a concern, however, because the last few pages of this document are lists of different organizations, specific numbers and emails to reach out to. And with such a high turnover with agencies with funding happening, a concern that had come up was January is right around the corner. Are all of the agencies that are listed in this document even going to be able to provide services in the next year or the year after? And so that was something that we were internally discussing and figuring out for quantity of printing, maybe limiting the amount of printing so that it was done on either a quarterly basis or every 6 months, reevaluating how many resources were needed, so that way, if there were any changes that needed to be made, we could always go in and adjust the document, and not necessarily print out, for example, 10,000 copies and then have to throw away, 8,000 of them. Another topic that had come up was looking to include language regarding the protocol for court-ordered HIV testing of individuals accused of sexual assault. This was a law that was passed in 2006 and was not listed into the document. So we're looking right now at adding that into a specific section where it would be best fit. And we are very fortunate to be working with Lori, who's doing an excellent job putting this all together for us. And the last thing that we're looking at is currently working with Lori to ensure the accessibility of the links that are throughout this document. So we were told that it's part of the mandate that this document has to be printed, but we are also looking at including a virtual copy that could be housed on various websites, whether this organization or this committee has a website that it could be housed at, or if it's just going to be housed at the Department of Public Health, wherever. It would be, people would be able to open up the document and click the links that could go directly to the websites. In review of the brochure of the document, there were a number of links that were sort of embedded, that it would just say, click this link for this resource. But if you're looking at a printed version of this, you obviously aren't going to be able to tap the paper and suddenly go to a link. So we're looking at structuring a little bit at the footer of the document where it would say the URL, so that people who are given just a pamphlet and they don't have, for example, a cell phone or access to, they're not looking at the document on a computer, they would still be able to see where that link is going, so they can still access those resources. And then also looking for increasing the accessibility, putting QR codes where it would be best fitted to allow for an easier capability for someone to scan the QR code on their phone and have it go right to the website, and then they don't have to type in the URL. I think that's about it. Is there anything that I might be missing on?
Beth or Lucy, do you have anything that you want to add?
That I would add, which I appreciate going through all the listed pieces. We did talk at one point about printing the booklet and then having like a bifold, because my understanding was that it's basically a 8.5 by 11 fold. Yeah, at least it's what it was in the past. So we talked about possibly printing the booklet and having that insert, right? So having like a 1-sheet insert that would go organizations on it. So to your point of printing a ton of them, you'd be updating the insert, but not updating the bulk of the information that's in it, just the contacts for folks. So that's one thing that we talked about as a possibility, if that's helpful. The other thing is that in terms of the challenge for us, and we had a conversation about the HIV testing of offenders or folks who've been convicted of harm, the challenge is who folks go to. Like, that also needs to be like a person or an office or that's not us, right? I'm with the Alliance. We had a hard time identifying who would be the right resource to call or to be listed as a person or an office to go there to ask for the mandated testing. I do know that like when we've gotten those calls, we tend to go back out to the state's attorneys, and that's where we ask folks like locally, how exactly does that work? Confirming everything in terms of the court side. So that would be one consideration. It's not that we didn't talk about it, it's just we could not figure out where that would go. And then the other two things I want to offer up, which we've always said, we're super happy to host it on our Alliance website. I had heard in the past that DPH wanted to host it on theirs, but please know that you can always use us as either an additional resource, as another, we can link out to yours. And then the other thing, I'm so sorry, this is my cat, which some of you are familiar with, who is joining our meeting from the other room right now. If you hear the noise, I apologize. what we have started doing with an external communications consultant that we used is they pay for software essentially that is like a QR code that you fix the link on the back end, but the QR code never changes. So for us, it was another way as we're looking, because we're doing some material development also for first responders. And we also are concerned sometimes even just links change, right? In terms of not that offices go away, but just the links change on websites. So we now, everything we do is using that software that these folks use so that you can then go in and it always stays the right link because you're just updating it on the back end and never needing to replace the QR code. So that might be another thing that's helpful in terms of a way to sort of move the electronic piece forward. But again, please use us as a resource. We appreciate all of your support. We're always happy to troubleshoot and try to think of ways around some of the challenges that you named.
Absolutely. Thank you so much for that. I can tell you that the current style that we were looking at is it was 8.5 by 11 sort of format, and it's almost like a packet. So not in that folded booklet version that you were talking about. But the idea of having to go to the extent of having it where then you can have an insert. I love the idea, but that the funding to create that style is something that we would definitely have to do some research and look into. And we can get back to you on that.
So just a quick point, because the packaging may be is an important portion of this, is it's 8.5 by 11, but it folds down to booklet size. So it folds down to 5.5 by 8.5 right now.
Which is similar to what the size was before.
That's what I thought.
In the
Okay.
old one.
Okay,
Yeah.
just want to ensure. So I guess is it the folder, Beth, that you were referring to, the outside, the folder that it gets inserted into?
No, what we've done with some things in the past is when you have that, right, like it's literally, because it's just that one sheet of paper folded in half, that literally we have just then taken a regular sheet of paper, printed the things the same way, like you would have it as a booklet and just literally inserted so that it's the one sheet of paper that comes in and out in terms of those resources. So that you can print, right? You're going to get a better cost printing in bulk, right? To go into all the safe exam kits, all that kind of stuff. But that if next year, to your point, some of these businesses or organizations don't exist or things like that, or there are changes, you're just pulling out that sheet of paper and sticking in a new one. So the labor is sort of, I get that side of it, but it's all stuff we've had to do. I mean, we've done it for years, so it's all stuff we've had to do. And my guess is like we can help do that at the Alliance or in other places. So it's just a matter of needing it to be formatted to just have a sheet of paper slide right in there.
Yeah, because right now the list of resources is several pages, so we'd have to reformat it to fit, like on the front and back, or we're happy to do it. We just need to. We just have to. I just want to make sure that everyone knows we'd have to reformat that section as a separate piece.
And it doesn't. I mean, to just to say, like we don't necessarily have a preference for it. I think there's just some concern about like short and long term. So if we find some money to do it, but it's a small next year, if there is no money to print it, right, just sort of heading off some of the concern about the year to year identifying resources basically. But I don't have any personal preference, or the organization doesn't have a preference about how it gets printed.
So what would be the timeline? Do you, first of all, let me think. I'm just listening to all this and I'm thinking, wow, victims of sexual assault are going to have access to something that they've never had access to before at this level. So I'm very, very impressed, and I think it'll be a huge benefit. And I want to say thank you to all of those of you who have been really involved. And I know this has been labor intensive for the past 2 years. My question then is, what would be the timeline for revision? Like if you were looking at accessibility to links, are you talking about an annual review or an every 6-month review, where you would possibly need to make changes? What would that look like?
So typically whenever the Department of Public Health is assisting out with any sort of project like this, there's a lot of relying on the agencies and the committees that we're collaborating with to be able to provide us that information. So if you have access to knowing anything about the locations or where people could go to for help, and someone hears something relaying that information to us, we can always collaborate and continue to have a presence at this meeting, and be sure to engage and have that conversation. Like I said, maybe on an annual basis, and always revisit that just to ensure that the resource list is always up to date to the best that it can be. I mean, we're all human and we can always do the best that we can, but you know, if there's an agency that slips through the cracks and we learn about it afterward, then that's okay. We can make the adjustments as needed. But there is some accountability on both parts to be kind of keeping up to date on what's going on.
So next steps, what would we looking at if we come back here in January? Where do you think we would be at with this?
Lori, do you have an estimate for based on the edits that we were discussing previously for where we might be for January?
So we can submit the edits that we talked about next week for review, and then it will just depend on the availability of anyone to give final approval as far as the completion is concerned. But I assume that, you know, 5 to 7 business days would be sufficient. That I'm, you know, just throwing that out there. Of course, barring vacations and things like that.
And to another point that Lori just brought up, we would also like to hear directly from this group what the exact wording should be on certain situations. We don't want to get anything wrong, and for whatever reason, you know, say something because we think it sounds better one way, and then come to find out, you know, legally we just messed it all up and now it's no good. So again, it's part of that partnership where we're relying on you all as a subject matter experts to really ensure that we did get the wording correct, especially the wording. And then as far as the creatives and the links and the QR codes and all that, we can handle that part for sure.
Okay. Anyone have any questions? Okay, so I think if I'm understanding correctly, we can look for the edits as being the next step. Am I correct in saying that? Okay, so that we can have a chance to look at it, and then, but again, I think this is what I'm hoping is that we can bring this all together and tie up everything early next year, so that we can get this out on a statewide basis. And it sounds very portable as well. So it's not just for one group. It's something that can be utilized in many different ways.
And another option that we were discussing at a previous meeting was the idea of creating a template for a business card that could have a QR code and a website and telephone number where people can call for information, but having the QR code then go to the document where it would be housed online. So then that way, if it would be easier to pass somebody a card that they could, you know, put in their shoe, put in their pocket, put discreetly wherever they needed to, for whatever purpose. They're not walking around with a packet or a booklet.
And so, you know, I think we had talked about the utilization of this both being utilizing current technology with the QR scan codes and links, but also for those who don't have phones, I don't, you know, we're always going to have that need for the printed equivalent of it. But any questions at all for our DPH, the Alliance, on this subject?
I just have a question. I really like the index card thing with the QR code. I think that's very portable for emergency departments to kind of house, and it doesn't get lost, pamphlets and stuff. It's a lot different. You can put it places. is that something that we can talk about then once all the edits are done and everything? Or is that something that has to be discussed like much later, or who
Oh,
decides?
no, it would just, yeah, we could put together a design of what that business card would look like. And then it's just simply listing the information, and if there were any appropriate logos and such that you wanted to put on the card. But between Lori and the Office of Communications, we would be able to put, you know, something together, and we could get everyone's approval on what that would look like as well. And then
And even to have the like the website, you know, like the most
Yep.
generic where you can lead to something is fine. Because even if people don't have phones, hopefully, I mean, we run into this all the time, right? We tell them to call 211 and they don't have a phone, like they have to go publicly. So whether they go to the library, get on the internet or somewhere else, I mean, it is doable, or you know, they talk to friends, or, you know, what have you.
Absolutely. I did have a question regarding the quantity for the print, because if I'm going to go back and look for different prices, is there an estimate, or could we receive at some point, doesn't it, you don't have to tell me right now, but maybe an estimate of how many would be expected to be printed for a yearly quantity, just based on either historically what has been done, or based on latest data and statistics, if that number has fluctuated, and what an estimate might be of what the need is for printed, that would be helpful.
Beth, is that something the Alliance, in terms of numbers, could help provide an estimate?
I mean, perhaps it is. I wonder, like, for us a lot, and just to clarify, we actually are working with a designer and have we've already designed a palm card for first responders, including folks in emergency departments, for the Alliance. Already talked to OVS about, and we have a placeholder for this document, thinking that this would be another good link to have go in there. So we'll, not to do double duty, obviously you can have one for just this piece, but just so you know, we're doing that as a coalition. In terms of numbers, my challenge is that probably for us, by and large, we would be orienting folks more to an electronic version or using palm cards versus the print ones, but for them all to go into packets, right, for evidence. My assumption is this is going into the packets of folks after evidence collection, and then to have some on hand. So maybe what we can do is go and look at those numbers statewide and like see the average over the last 3 years and just kind of overestimate as a way to think about, because I think that's probably where we use the bulk of them. Not that we won't sometimes use them as a coalition in trainings and things like that, but in the same way, like most things now, most people are asking for something that orients them to an electronic version versus taking larger, you know, documents from us, right? Like we've just really have seen that. And over the last 2 years, that's happened even more because more people are just so oriented to being online. Not that there are not certainly disparities in access for sure, but I think that that's probably how our coalition would do it. So maybe the best way to look at is the kit numbers and then kind of overestimate from there.
And that's
Great,
where
thank
I was
you.
going with that. Thank you. That's where I was going with that, Beth, because we already have the kit tracking numbers with the and the kit tracking form with that. So you know, what I'm seeing and what I'm trying to think in terms of is tying everything together, because we have, you know, so many threads out there, you know, with this and the kit tracking, and you know, we're talking about business cards. So we want to make sure that what we're all doing is going to come together, so that we don't have, you know, somebody doesn't have a, you know, piece of paper with a QR scan code for this and another business card with a QR scan code for that. Does that make sense to everyone?
Absolutely.
So that's the kind of thing that we want to make sure, because, you know, this dovetails right into the next thing on the agenda, which is actually a statewide discharge packet, which I continue to be asked for by hospital administrators. And so the pamphlet was kind of be a little bit of a, shall we say, a cornerstone of that. So we're looking at, you know, something that brings everything together in one place where you have the, for those of you who were not here last time, we talked about a statewide discharge packet that would take 2 forms. Lori, yes, you have your hand raised.
Yeah, I don't know if Mary had her hand raised before me.
That's okay, Lori. Go ahead. I'll follow you. Thank you.
Okay, these are sort of just some housekeeping things that maybe we don't have to talk about right now, but I just want to know who to reach out to. So one is there was a comment Dante was asking about the, there's a reference in the copy that says chat at end sexual violence. Who can I talk to about how that gets initiated?
You can talk to me. It's just on our website is how you go through to chat.
So someone would go to, okay. So I'll write a some sample, a sample of copy of what I think it should be, and I'll send it to you and Dante to say, yes, that makes sense.
Perfect.
Okay. And then the other thing is we didn't talk about translation, so I don't know if you want to save that for another day, but
no,
while
please
we're all
do.
here.
Please do. Please do.
So Dante, I don't know if you want to take that topic.
So at the Connecticut Department of Public Health, we have vendors that we pay to do translations for us. We do not have an on-site employee or people who do it internally. So to have the document translated into other languages would again mean finding additional funding to then pay an agency to do that for us. So that I would imagine everybody would like this to be in Spanish as well. And so that's something that we're going to have to look into for additional funds to go towards that, which we can provide an update. And real quick, I'm going to take this opportunity. I'm sorry, I did have another meeting at 2:30. I'm going to put my contact information into the chat box. And if anybody needs to follow up, and I would like to talk more with Bethany and Lori, and thank you all again for having us from the Department of Public Health. And I look forward to continuing this conversation with you all into the new year. Thank you, everyone.
Thank you so much. And Mary.
Thanks. I just wanted to mention on the numbers piece. I know Linda and I had talked briefly about the fact that this, I believe, is also the brochure that the clerk's office is tasked with providing to victims when the court orders HIV testing. So just when we're thinking about numbers, I don't know what that number might be, but I think it's another pool that we need to think about where this document would need to be supplied.
Okay. There's probably several resources that we will need to look at. I know we also have the billing at OVS as well that can be considered. So I know there's we're going to have to compile our list of resources that we need to look at in terms of, trying to get a handle on the number of print so that we have some basis for that. So does anybody else have any questions? Comments?
Denise, has anybody talked to victims themselves about what goes into this?
I have not. But we do have a victim survey that we've been working with the Alliance on since the beginning of the program, that allows them to provide feedback on the services they provide. Beth, I don't know if you want to add to that.
Is that we've not been a part of doing that, but we have a pretty active Victim Survivor Advisory Council, as well as just a number of parents and other folks who aren't on that official council, that we would be really happy to have them give you some feedback, or have them, if you want to do like a little quick focus group or something like that. I'm positive that we could get some survivors together for you with varying experiences to be able to give feedback if that's something that you're looking for.
Right, because we always know what we want to tell them, but I think it would be interesting to know what they think is most helpful and maybe what should be more emphasized.
Yes, that's one of the reasons we have a victim survey. We've had it for, since the inception. We actually, I know, I wasn't going to go into this because I think it's going to be more of a January topic, but I believe that Beth and Linda have been having some discussions over, because we were looking at the idea of a statewide survey that would be part of the discharge packet that would evaluate the services and help to identify the gaps in services. And that was the intent of it, to see, where do we need to improve and what are we doing right. So I think that's going to be basically a big 2023 project for this group. Does anybody want to add to that? Okay, so just kind of sort of picking up with that theme, though, what we have is kind of sort of almost like a multi-level statewide discharge packet that those who go through the SAFE training, and just to give a little bit of a context to it, since we started training years ago, people have wanted nurses, and not just those who go through SAFE training, but I've had hospital administrators, ER managers ask, is there something they can put together for their victims of sexual assault that would compile all the resources together? And we hear this echoed in every class. We want information we can provide as resources. And so way back at the beginning of this advisory committee, we started looking at this a couple of years ago, but it was in conjunction with the brochure, the HIV brochure, because that was really the corner piece. That was the piece that was had been so outdated. So that had become a major focus. Now everything else needs to be added into that in a modality that allows victims of sexual assault to have access, whether it's a QR scan code or a link or in print or a combination of all those three. In kind of going back to what I was talking about a few minutes ago, where everything needs to be interchangeable. Excuse me. We don't want people to end up with all these QR scan codes and they don't know what it's to. We want to make sure that everything ties together in a way that's very simple and easy to understand and easy to access. So to that point, we were looking at, and this is what we had talked about at the last meeting. We were talking about inclusivity of, the different websites, not the specific information, but the websites for OVS, for the Alliance, for CCADV, and maybe, maybe just the Safe Connect number there, as well as the statewide survey for recipients regarding the quality of services they provide. And that in the last meeting ended up with the discussion about the business card and it ended up being a discussion really about how QR scan codes work. If you have the QR scan code in the brochure that DPH has just reported out on, can a QR scan code on a statewide discharge packet access that QR scan code? It's a multi-level, it's a technology thing. I believe we have somebody here at the Office of Victim Services who has been working with QR scan codes. Linda, I don't know if you want to mention that at all or not, that you and I had talked about.
Yeah, we at the Office of Victim Services fairly, I think successfully, launched a 3-tiered informational outreach program. There you go. Wasn't prepared to speak, so let's come up with some words. Outreach program a few years, probably 4 or 5 years ago, and our colleague at OVS has accessed the software that Lori was mentioning that, and I can't speak as eloquently as Beth just did, but as I understand it, whatever happens with changing of our website, our judicial branch website, that does not break the link to the QR code. We have used those, and when COVID happened, we admittedly have not followed up on that. Mary and I actually had a very brief conversation a couple of weeks ago about re-energizing that process as a result of trying to meet some of the obligations we now know through the outcome of the victimization survey. So we have some experience with that, and I hope that was sufficient, Denise.
Yes. Does anybody have any questions? So I realize this is getting a little on the technical side, but I think at the end of the day, what we're looking for is embedding in a single cohesive document that, you know, we want victims to be able to feel comfortable with the instructions they're getting. We don't want to put them in a place where they're having to work at understanding what is this. We want it to be a very simple QR scan code that leads to whatever they need for it to lead to, that it's very simple. One thing links to another, and they can go to write what they need. And so that's kind of the outcome that we're looking for and have been working towards, and we are within inside of it after 2 years. So does anybody have any questions on that topic?
Can I just ask, Dr. Cordiano, you had mentioned earlier about having a QR code or something like that in the emergency department. If we, and there's a lot of, you know, I don't know exactly if a PALM card is a business card, but what do you see when you made that statement? How if we created this QR code on a PALM card or something, how do you see that would be beneficial to the patients that you provide services to?
Well, QR codes are very interesting now. They're a lot. I don't understand them, admittedly, in terms of how it happens, but I know like they're used all the time. I mean, I scan them with my phone. And we actually had like a big project at Hartford to like actually put a QR code as like a layout. So like on your emergency department website, you know, that's connected to Hartford Hospital, there's like a link and people get a sheet with the QR code, essentially with the map of the ED. So I can just foresee, I mean, if it's on a card, it's very easy. We used to have these packets, right, for victims, and social work would give them out. But at night when we don't have social work, we knew to get them from this, you know, closet, and then, you know, the cabinet is now no longer there because they've redone the emergency department 18,000 times. But we have areas like at different pods at the desks where it's very clear, you know, in a folder is X that we need. And it just seems like a very simple thing that education wise, you could say to all the doctors, like, here's a very specific, like easy link, you know, or providers, residents, like APs, everybody, you know, it doesn't have to be the physicians, even nurses, you know, like very easy forward. And frankly, what my understanding, I mean, once you kind of scan it once, like they can flick the card in the garbage and just have like, you know, have seen it like on their phone in the emergency department. They don't have to physically go away with something that could potentially, you know, be an issue either. Like they could look through and say, okay, I can remember this. Or you provide, it is for providers who then could scan it and look and do whatever. I mean, I just think it's a lot easier. I mean, you could even put an envelope in the patient bathrooms. It's not like there are that many, you know, like we used to do for questions that way years ago, right? When we were just starting to ask domestic violence questions, like we would literally have sheets, right? With those like pull-offs, you know, that like at the beginning, this is how I remember starting, you know, like whatever, 20 years ago. So, you know, you almost could have like something like that where people can access it, or, you know, it's part of registration and you can, I mean, I don't know. I think there's a lot of different ways, like we're talking about the HIV testing and in Connecticut and that law that like, you know, we have to give them information that you could get a test. I mean, it's kind of like information about whatever. it just seems very easy for providers and emergency departments to kind of have, it's so small.
Mm-hmm.
You don't have to like store it big packets in a cabinet and folders and hope nothing happens and then try and find one. And oh my gosh, this is the last one. How do you get more? I don't know. It just, business cards kind of are way easier, I think, to have a lot of them, and they don't always get used, but you have them if you need them.
So can I ask,
Yeah.
so if they scanned this, would it be, something that would be a history on their phone that they could go back to when you say they don't even have to keep it?
Well, that's my understanding. I mean, I will not say I'm technically competent, but when I have used them, if I don't delete that on my phone, like I can, it might be 18 pages back, but I can still get it. And I know people are way more savvy than I am. So my guess is yes. I think Beth is like nodding her head, but
yeah.
Anything, it just opens a link basically. So now that you can close the link, you could open up in one of the, like if in Apple's, it's an incognito window. So you could quote unquote safely open it up to navigate.
That's my
There would
thing
not be a
about the
history
safety.
remembered.
Yeah.
Which we could put something on there that says like a little asterisk. Again, it's, not everybody will still do it even if you put that on there, but orienting folks that they can open it up in quote unquote safe mode, like open up a browser window on their phones in safe mode, which does not keep cookies. It does not store the history. So if they had it there, they could save it for later. Absolutely. They also could then look at it, right, and then delete it with no history on their phone.
Yeah. That's the thing about it. I wanted to make sure that what we were doing would be safe.
And I think, Alexis brought up an important point about, the old version of having paper trail. You have to go home and hide that maybe, right? You may not disclose with everyone that you went and had a sexual assault kit done, but you might have a massive packet of information that you have to bring and hide from other people. So, I mean, this does allow the option of more discrete information sharing.
And I just think also like there's so many times that we get stuff and then like you see it on the, floor, the ground, and there are lots of different reasons for it. Even if you just drop it, you have like a whole patient belongings bag, it just falls out. I mean, just unintentionally, it's hard enough sometimes for us to locate supplies that we need. And then, if somebody moves them or doesn't realize the packet, like they were always just, I don't want to say an issue, but it was always like, okay, well, where are they and where do we get them and where are they now and who moved them and how do we, somebody better copy on this, seems to be the last one. If nobody did and they just took it, well, who can get it and where do you get another copy? It's like.
Oh, that sounds like a supply of sexual assault kits in a hospital there.
Please.
Yeah.
I apologize. I'm going to try and get into my car because I have to go pick up my kids. So I should pick up this meeting or have to re-click, but was there anything else that I could potentially?
No, I think we're going to talk, we have a couple of more things on the agenda to briefly cover.
I'll come back on. I need to like shift.
Okay. All right.
All right. Thanks.
Okay. Yeah. Does anybody have any more comments or questions about this? I think a year from now, we're going to have a wonderful tool that we're, I've said this before, but I think it's just a matter of figuring out the nuts and bolts of the QR scan code, and the technology is really what it sounds like. So the next thing on the agenda, if no one else has any questions, is the website development. And I believe what we're going to do, Linda, we're going to hold that until January. Is that what you want to do?
No, I can give an update.
Okay, all right.
I had reached out, well, Denise and I had met with the Judicial Branch Web Board several months ago about the creation of a website link that was specifically for medical providers who are interested in becoming part of the Sexual Assault Forensic Examiner program. And as with many of our schedules, I jumped in right after that. Well, and then there was no movement on it, and realized that there was just, it kind of fell off everybody's radar. So we've re-engaged the web board, and they more or less said that when it's available, they will do the review and editing, and it shouldn't be a long time once it's the material submitted for it to be up. So at that point, I entered with great enthusiasm the creation of melding many of our documents that we currently have, trying to one voice them, trying to vision them as drop downs in a way that the judicial branch has external, has links, has pages for external stakeholders, and then life, as often happens, and I've not touched it for a few weeks. I did spend about an hour and a half on it before this meeting this morning. And as I was saying to Denise prior to the beginning of the meeting, now that I've stepped away from it, I see some of the challenges with one voicing the material, but also are thinking about a couple of different ways that it could be looked at. And so I see Sherry's on this website. And Denise, I hadn't said this to you, but I would like to have a couple of people, maybe Sherry and a couple of our other safes who've kind of new to the program, look at it and see if it would have caught their attention. Kind of to Ann's point, you know, it's great to put out what we want to, but is it actually helpful for those who are seeking additional information? So I'm really hoping that within the next, I don't want to overpromise, but I'm hoping by the time, Denise, you return from your time off, that it will be on your desk waiting for you.
Wonderful. Thank you so much. Just in case anybody wasn't clear about that, the website is actually intended for healthcare professionals who are interested in becoming a part of the SAFE program. You know, we have been kind of sort of promoting the SAFE program and SAFE training for years, literally by word of mouth. And I know Sherry in this past year has been a wonderful help in doing mass emails out to the Connecticut Nurses Association and the Connecticut League for Nursing, which has actually produced quite a bit of interest. But we realized the need for a central site that was public, that healthcare professionals could go to. You know, what is a SAFE? You know, what is the role of a SAFE? What does being a SAFE entail? What's the job like? So this is the kind of information we want to provide to them to allow them to decide before they ever even approach me or anyone else about, you know, hey, can I take a SAFE class? Can I be a part of the SAFE program? It gives them a real understanding, a better understanding of what the role is. And to that end, I will share with you in this class, we just finished this fall SAFE class week before last. And this is what I heard from them. Many of them, you know, you know, when I ask for feedback, and I do ask for feedback, one of the things that they said was many of those, especially those coming into the program who were not working in hospital emergency rooms, they did not understand what the role of a SAFE was. And they said, this is something that we really do need to provide more information on. And we are talking, we're not talking about new nurses. We are talking about nurses who have been nurses, some of them for decades. Many of them have master's degrees in nursing education. 2 of them had doctorates. And here's the feedback that I'm getting. So I'm hoping that this website will provide much more information in a way that allows people to have more of an understanding of what this specialized role is really about. So there's that, you know, something that we hope will be very useful in 2023. Does anybody have questions about the website? Okay, lastly, SAFEs in Connecticut. This has been, and it's been interesting. I have learned we're maybe not quite ready to provide the Connecticut Hospital Association with a list just yet because, and Denise Poncini, I'm kind of looking to you. We might need to work a little bit more on this. You know, in the last, in my last report, thank you, Sherry. In the last report, I really talked about the number of safes being kind of, in the low 140s. And I just finished doing an actual count that I currently have, including the fall class. And the count is 139, but it's not as straightforward as it might seem to get a count. First of all, not everyone who has a current SAFE certificate is a practicing SAFE. There are SAFEs who are coming to these annual competency days who applied to be a part of the SAFE program, but before they could ever do any cases, they resigned. But they want to keep up their certificate. So we have people who are doing this who have never done a case as a SAFE. Okay, so there's that aspect. We also have people who have current certificates who just took the class, but who are saying, I've become a traveler, or I've just gotten my doctorate, or I've changed careers, or I'm retiring. And even though they're current, they have current certificates that say they are SAFEs in Connecticut. They're not practicing SAFEs, or they've said I'm not going to do this anymore. And so I want to look to this group in early next year to maybe perhaps take a second look at when we have a list of SAFEs in Connecticut, what does that mean? Thank you, Lucy. Lucy, I know Lucy had to leave, but we want to take a look at exactly how do we want to communicate this list to others, and what does that list look like? So I'm going to be looking at with Linda and Mary and our legal department, and perhaps with this group, and take a look at what that actually means, because I know there had been some talk about viewing this group as experts, but this is the reason why we can't view this group as experts. So that is something that I'm having to take a hard look at. Does anybody have any comments or questions about what I've just said?
Denise, I do. Oh, sorry.
Go ahead, Alexis.
It's Alexis. I apologize because I'm in the car. But so I am struggling very much. I am like in the process of trying to round up with emails. Like, we are having a lot of, and a lot is, an increased proportion than what we knew before. And who is doing them, who is responsible for what, and how this is happening. And honestly, like, we're kind of struggling with it. There's different opinions about how long the patient should wait. Do we wait to see if a SAFE is on the next day? Do we just do it? And there are a lot of varying opinions. So this is very near. I don't know, Marielle, you might be able to say how other hospitals, obviously the non-7 or the memorandum of agreement or whatnot, they probably just have providers do it. But where we were very complacent and used to SAFEs, now we're like, oh no, what are we doing? Who's responsible for what? And it's become a big deal lately.
So this is Marielle. I think that's interesting to hear, Alexis. I'm not surprised to hear it. I think you're right about the group of hospitals that have been able to activate the state SAFE program. Always hope that you're going to respond as first, and then you don't have to worry about your own personnel. I do think it varies by hospital. There are other hospitals who haven't been able to activate the SAFE program, so they have their own pool of hired SAFEs. They've had their own staff be trained, and the same conversations probably still go on about, is that person on? Is there always a SAFE available 24/7, or do we go back and rely on our providers to do it? I do think from the survivor standpoint, we need to remind hospitals that no, we probably shouldn't make them wait for the SAFE to be on if they can get the kit done sooner, or at least give them the option, because, I think they have the right to understand that, the wait could be very long to get a specially trained SAFE. It could be the next day, it could be many hours, when they just want to get it over with, and a provider can do that for them. So, it's one of those conversations. But I think coming back to the list, which is what I was going to comment on, Denise, I think part of the reason we thought about the list, if I remember correctly, is that, we have the whole conversation around, who is truly a SAFE in Connecticut,
yes.
right? And this list really is a list of people who have taken the actual Connecticut training and can be actually considered as safe in the state of Connecticut. Whether they're practicing or not doesn't really matter at that point. It's really just a documentation of they have kept up their certification. And therefore, you know, if you are hiring a safe, you can check that list.
Yes, you can. And that's the black and white of it. But I think it needs to be very clear in the language. And Denise Pancini, I'm kind of looking to you to work with us on this, because I know you were working with us a little bit on this before. The language needs to be very clear that when you look at this list, it is someone who has taken the class, has completed all the requirements, has a current certificate. But you can't interpret that. You know, the language needs to be so clear, crystal clear, as to not imply that they're getting someone who may be a practicing safe when that's not maybe the case. So we need to be crystal clear about how this language is going to be worded when we provide this list.
Because, you know, we're still running, you know, obviously, Denise, as you know, there's still going to be times when an out-of-state person comes into Connecticut who has been trained somewhere else. And while they can still do a kit here and probably do it better than your average provider, while they use the, you know, the Connecticut guidelines, until they've taken our course, they can't actually consider themselves or sign next to their name that I'm a safe here in Connecticut. And of course, we want to be clear about that. And at least this list would help hospitals understand who they've employed that could do that and who they have to remind as, you know, you're acting as just a provider right now doing the kit, even though I know you have a level of training maybe the average nurse doesn't have. So I do think, you know, I would love to still see the list come together. I agree with
absolutely.
you on, you know, we do need to figure out the finer points of how to make sure the list is helpful, but still clear. And
yes, and so absolutely, you know, that's one of the things that we had wanted this committee to have oversight of was maintaining a list of those who were currently had that current certificate to practice as a safe. But I just want to also not, I think sometimes word choice is very, very important in these things. But also I'm going to speak to Alexa's point as well. You know, and I did tell Alexis, you know, we all know the SAFE program it's literally an extension of the emergency department. And when the pandemic happened, it happened and it affected not just staffing at the hospital level, it affected staffing at the SAFE level. And we have never been able, nor would we ever be able, to guarantee a safe. We've been very clear from the beginning about that. And Denise, you please feel free to jump in, but the MOAs are very clear that hospitals are responsible for doing the case when we cannot respond.
Please don't get me wrong. I totally know that. It's absolutely our issue and like a provider and who's going to take the lead. And I was doing this from CSEP, but I'm going to have to like deal with this on a like personal hospital, like employment thing, because it is like, frankly, become an issue like for, you know, patients. So I'm just saying, like, I totally get it, but I can't even get my own department to say safe and not sane, let alone, you know, 84 residents that are from many different states. So like, you know, it's just good to be clear, and it's helpful to be from a knowledge standpoint, you know, on the committee. But it's like, I'm one person at this one hospital with no power, but just some knowledge and like trying to explain and work it out, you know, I mean.
Yes, and you know, I think we all understand the frustration of it. Some of us more than others. You know, if you think about how many nurses there are in Connecticut, and when I talk about the number of safes who are currently have certificates as being 139, that's a pretty elite group. That's a very elite group, in fact. compared to the thousands of nurses out there. Now we are working at, and I'm hoping to get back with CHA with this next year, but remember we had tried to offer not safe training, but care for the sexual
general
assault
training, yes.
general
Yep.
training, a 3-hour training session. And Marielle, maybe you want to speak to the registration rates for that.
Yeah, and I think part of the problem, Denise, is I think we heard from the feedback. We did 1 or 2.
Yeah.
Oh yeah, Pat did 1 and you did 1.
Yeah.
We did it virtually because at the time that was, still what we needed to do as far as COVID guidelines were really in place. It was the best option. But I think for the average person who was taking part in it, they didn't mind the first part being done virtually, but the actual part where you go through the kit was really tough. It just didn't translate. So I think we've been starting to bring groups back. So I was almost thinking, when you get your new program person and we start thinking about this again, maybe it's more of a in-person opportunity again. And I think registrations, it will depend on the time of year. It's always a little bit of a hard thing to and because there's such a nursing workforce shortage right now, that's always the underlying thing for everything that we do when it comes to hospitals. So that's the other piece that we all have to work in. But I still think people found it very valuable, and I do think it's a good opportunity for us to go over things like what Alexis brings up that we can help guide hospitals about.
Yes. So, we will continue to work at, there's basically 3 avenues. One is the SAFE training itself. We continue to offer that 2 times a year to those who are eligible to take that class. We continue to be open, if somebody wants us to do a hospital training, we are still virtual. Judicial is still training virtually, but it's still training nonetheless. Knowledge is always a good thing. And my personal opinion is you can't have too much education. And then there's, of course, the response program, and we continue to reach out. Sherry Watson has been invaluable with that. We have 12 people coming into the program right now. Sometimes our classes have been 12 people. So that's a huge increase right there for us. And we're looking ahead to the future, and we have lots of people who are interested in the program. And the encouraging piece is that while ER nurses themselves, the hospitals continue to send ER nurses to train those who are able to do that. But what we have learned is that if we reach out beyond the ER to nursing subspecialties, there's quite a few nurses out there who are genuinely interested that are not working in an ER. Maybe, one of our nurses right now who's doing quite a few hours, she's not somebody that we would have ever reached. She's a nursing professor with a PhD, but 20 years of labor and delivery experience. But because of her life experiences, this meant something to her. And she has become really one of the core group. And the more we reach out like that, the more we reach people. And quite a few people are actually interested that we would never have reached were it not for Sherry's emails out there. So we will continue to plug away at it. And I'm very hopeful that, we've been at this for 12 years, but I'm hopeful that in another 12 years, the story will be completely different and SAFEs will be prevalent in every hospital. But you're never going to ever reach a point where it's 100% every time. And I think the key piece to this is we just keep trying to educate at different levels.
Denise, I'd like to say if something, and we're planning on covering this in the SAFE in Connecticut update, but I think Alexis raises a point that's been reflective in conversations that you and I have had over the last many months, if not a year. And it's a struggle because we understand that the hospitals that we have these signed contracts with have become to rely on the program. And we know that that has been a good thing and also a difficult thing regarding the reliance, but the loss of, and you call it credibility, Denise, in some respects, the loss of the number of safes we currently have has drastically reduced our ability to respond. We are responding to under, Denise, is this, and again, if you were going to deal with that as 6, I apologize, but I really wanted to bring this back around to what, like I said, Alexis was saying. We're responding to about 30% of the cases, if that.
It was low at that point. This past month, it has been about 50%.
Which is still much lower than 2-3 years ago when we were responding to well over 80, if not 90%. So that's something that Mary, Denise, and I have talked about consistently, is how do we regain our kind of our position? How do we re-engage the confidence of the hospitals that we will actually be there when they need us? And we very much understand the stress that our lack of a cohort of safes have put on the hospitals. So for me, it's been very eye-opening, and I think it will also help us create a better program, and maybe a program more in tandem with the hospitals as we go forward. So again, if I took some of what you were going to say, Denise, I apologize, but I really wanted to make my own comments to what Alexis was saying.
No, that's fine. Just so y'all know, when the hospitals go to activate, it's a web-based activation system. So they have this computer screen, and on the computer screen, the way it's designed, it says, if you have not heard from a safe in 15 minutes, call this number. This is my phone. This is my phone. And I cannot tell you how many times I have been called by hospital ER managers and charge nurses who say, we can't, we just can't, we can't. And I'm sitting here saying, I wish I could. I wish I could. If you have questions, please let me know. I'm happy to walk somebody through, but you do, you know.
That's exactly the thing, Denise. Like my patient died of a medical condition. We couldn't get, we have 8, 12-hour wait times, and then we have like sexual assault, and they get into a room, they're prioritized for a room, etc. But it's like, I can do a safe, like I could do a kit, but like I'm kind of the most valuable, if you will, or the most scarce resource, right? Like overnight. So if I go into a room and then somebody is coding, well, I'm going out, like, so it's very hard. And then do you say, okay, well, we only have 2 residents. Do one of them go in? Well, they have to do 1 kid. So it'd be a good time, maybe towards the end of their shift, or they can be taken out for an hour. Like they're real-time concerns in terms of like, well, we can't even get a nurse to start the collection for 8 hours because we're already down, 5 nurses just for, all the other stuff. It is like a crazy, amazing puzzle that people would not even, like, many people wouldn't even understand. And then you're kind of throwing this into the mix. And there's not a right answer necessarily. We're doing the best we can, but it is a big problem.
It is. And we have, one of the things we tried to do, and I do think it has helped, is the judicial branch did absorb the cost of the course. so that we weren't charging for it. But when I talk to ER managers, it still comes down to how much staff they can afford to let go to train. And they have to also pay for that time. So I understand that many of the hospitals will only pay for a certain amount of education for these nurses, and the SAFE course eats that up in the budget. So there's a multitude of considerations. So it's not just a matter of we could, even if I had the resources to train 200 people, the hospitals wouldn't be able to send 200 nurses or healthcare professionals. They just wouldn't be able to. So that's a constant concern, and it's like, how many can I send? How many can I afford to send? Is the what I hear from the hospitals. So it's kind of a little bit of a merry-go-round, but we are working on finding solutions. I will share with you that I talked with my counterpart and a mentor in Maine about, how many, about basically the logistics of the program. How many do you train? How, and I'm looking at what can we put online? What has to be in person? Who's the qualifications to teach for what? So we're revisiting some of these things that may perhaps be, variables that we could work with within budget, but at the end of the day, it really comes down to, we can offer all the resources we want, but the hospitals are self-limiting in how many nurses they can and how much staff they can send to train. So I know Yale, they try to send 5 or 6 people every class. So I think it depends on a lot of different things. We will continue to work on it. Does anybody have, I'm kind of looking at the time. Does anybody have any comments that they want to make? I know this has been kind of a tough conversation. Okay. So the last thing on your agenda is new business. I don't really have anything for new business other than to say, just to remind, especially for anybody for those who are new, the meetings do take place the second Wednesday of every month. They are virtual from 2 to 3:30. And because we meet every other month, those months are January, March, May, July, September, and November. And I will be asking Cheryl to post the actual dates on the website, but for planning purposes, I'll just let you know that our next meeting then would be January 11th from 2 to 3:30. And I know we have, I have a note here saying, please provide input if you have any topics you would like to see this committee address. But I think we've already got a plate full for January. And so we will continue to try to wrap up the work with the discharge packet, with the pamphlet, with the website in the early part of next year. And I think there's going to be some work to be done on how to increase training. Literally a pickup of the topic we have just been discussing for the last 10 or 15 minutes. How do we get this training into hospitals? So I think that will be our major task for next year. And if you all have other topics you would think this committee can and should address, please, by all means, send that to me. Any last comments? Questions? Okay, so we will adjourn at 3:21. I hope everyone has a wonderful upcoming weekend. And thank you all for attending. and for all your input. Very much appreciated.
Thanks, everybody.
Thanks,
Nice to see everyone.
Okay. Bye-bye,
Thank you.
everyone.
Bye.